This podcast is for educational purposes only and does not provide medical advice or create a doctor-patient relationship. Please do not rely solely on this discussion. Always consult your own healthcare provider and verify information independently. If you're in crisis or experiencing a mental health emergency, call 911 or go to your nearest emergency department.
So I'm very happy to welcome Dr. Ammar Rashid, who is a Pakistani-Canadian physician and a leader in hospital medicine in Kingston, Ontario. He is the division chair of hospital medicine within the Department of Family Medicine at Queen's University, where he has played a pioneering role in shaping hospital-based care and education. Dr. Rashid completed his medical degree at Rawalpindi Medical University in Pakistan in 2006, followed by internal medicine training in Qatar, where he became certified by the Arab Board of Internal Medicine. He later moved to Canada to complete his family medicine residency at the University of Ottawa. And since joining Queen's in 2019, Dr. Rashid has been instrumental in establishing the first academic division of hospital medicine in Canada, serving as its inaugural chair. He is deeply committed to medical education and interprofessional collaboration, actively involved in teaching residents, medical students, and healthcare professionals. He has a particular passion for advancing hospital medicine as a discipline and also holds a Master of Health Professions Education from Queen's University. In recognition of his contributions, he was awarded the College of Family Physicians of Canada Annual Award of Excellence in 2022 for his work in creating and advancing the division of hospital medicine. It is with great pleasure to welcoming you to the Summit Neurocare podcast series. Thank you for joining.
Thank you to Dr. Hassan, and I really appreciate you giving me the opportunity to come to your podcast. And I also wanted to thank you for doing this series, which has been very informative for general public to try to understand different components of medicine.
For somebody who doesn't understand the term hospitalist or hospital medicine, kindly explain that to us in simple terms.
So it's a very good question because, it is still a term which is not very well known, and people still ask me, what is a hospitalist? So hospital medicine is a specialty or a medical care where a group of physicians, they manage anybody who is admitted in the hospital. So one can wonder, how does it differ from somebody goes and admits under surgery or orthopedics? So the difference is, in a hospitalist, they treat the patient as a whole. So they oversee all the components of their care and they try to coordinate with different specialties their complete management plan.
What does a typical day look like for you?
I will be at work around 8:30 in the morning, and essentially you will first see if there are any overnight issues regarding patients who are admitted and under your care. So you try to address them nice and early in the day, and you plan your day around that. So if there is somebody who is having more urgent issues, you try to manage them, and accordingly, you also will have some role in teaching students and residents. So you assign patients to them, and then they come and report to you, and then you address their questions and give them certain directions and also teach them in the clinical environment. In addition, due to my administrative role as division chair, I would have some meetings related to divisional matters, for example, staffing or recruitment.
So how often do mental health issues show up in patients admitted for medical reasons?
Actually, much more than a person might think of, and it could be in a few different ways. Like, for example, some people are already known to have a mental health condition, and you would know it very well. People who have chronic mental health conditions, they have higher prevalence of chronic medical conditions as well. So the risk factors are higher, and they have a higher chance of getting sick and going to hospital and get admitted. So we do see quite a lot of mental health already existing in our patients. We also see that, being in the hospital and having to go through loss of particular function can trigger certain, mental health conditions which probably were not diagnosed or not assessed properly before. We see a lot of anxiety and depression actually happening after they are admitted. So that also needs to be managed. And then we do see that it does impact. So if somebody is having an active um, ongoing depression or anxiety, it does impact their hospital journey. It does impact their rehab. Essentially, you can say that people who are mentally sound health wise, they will be better in the rehab.
So, what are the most common mental health challenges you see? For example, I mean, delirium, depression, substance use. What are the common ones that you would see?
Yeah, I think the most common one would be depression and anxiety. Although we do see a wide range of other conditions as well, like for example schizophrenia, psychosis, but the most common were depression, anxiety.
So, schizophrenia and psychosis would be generally pre-existing
Conditions who
conditions.
develop certain medical complexities, and they require rehab for that particular aspect.
Right. So, one thing a lot of people misunderstand is delirium. Can you just tell us in simple terms what is delirium?
So delirium, in a simple term, would be that if a person is admitted in the hospital, or there could be other risk factors as well, they will have they will develop a state of disorientation and confusion, which sometime can be an underlying mental health condition as well. However, we have to ensure that there is no other medical condition presenting like that.
Right.
So essentially, you have to make sure that they don't have an infection, or there's a long list of conditions which can actually present like this.
Mhm.
So and often we try to figure it out and manage it, and they get better.
I mean, how would you handle a situation where mental health affects their medical care? So, for example, somebody, as you mentioned, with pre-existing schizophrenia may have delusions of persecution, may quite unwell in that sense, but they're refusing their medical care because perhaps their delusions are impacting their belief system. So, what would you do in a situation like that?
I think that's where as we discussed in the beginning, the hospitalists, they manage the overall care of a person. You can also call it as a quarterback. So as a quarterback, we have a broad view of the whole situation, and then depending on the need, we can collaborate with a particular specialty to get the best care for our patients. So the medicine, as you know well, that medicine now is all about collaborative practice, and this concept of collaborative practice is growing. A good example of that would be that if we have a patient with schizophrenia and we have challenges where they are refusing certain aspects of their care for medical issues or rehab, we will consult our psychiatrist team colleagues. They will come and they will try to adjust their medications, develop a plan for them, which could include medications as well as psychotherapy and counseling. And so that's how we navigate those challenging patients.
So you've actually nicely answered my next question in relation to collaborative care and what does good collaboration look like between psychiatry and your division. But I will ask you this. I mean, when you do call psychiatry, are there other things that you can manage yourself in terms of regular depression and anxiety if it's not to that degree that it may not require psychiatry?
Yes, and that is true. So as hospitalists, we are trained to manage any condition at a level, where you can say it's not that advanced, not that complex. So we try to manage them, and the consultation to psychiatry, as an example, would only be when they are more advanced level of mental health conditions or severe depression, which hasn't been able to get better with first line medications, as an example, or and psychotherapy. And sometimes we need to go beyond that or augment the therapy, and maybe one medication isn't working and we are having certain interactions with different drugs. So when the pharmacotherapy is a little bit more challenging,
Meaning treatment, like medical treatment.
medical treatment is more challenging,
Right.
then we will consult the other specialties.
So you've also been working as a clinical director and as a division chair from an administrative point of view. So you see how things work on a systems level as well. So from your perspective, what are the biggest challenges currently in to good mental health care in hospitals?
We are lucky that we have a very good team of allied health and presence of psychiatrists on the site, which makes it easy for us to access it. I would say broadly, if you talk about provincial level or national level, if you are outside the bigger cities or tertiary care centers, I think there is lack of health human resources in terms of people who can provide that support, to build up that collaborative practice model. I think there is obviously, it as well, that there are very, the resources are limited when it comes to like psychiatrists in outside community hospitals, and so that's where it becomes challenging. The hospitalists may be like dealing with that alone, and trying to manage, maybe like through virtual care or maybe phone call. But I think what system will benefit from that is, to have more psychiatrists and more allied health and psychotherapists within the hospital setup,
Right.
across the spectrum.
How do you decide which hospitals should have hospitalists, which hospitals do not have hospitalists? How is that decision made?
So the hospitalist model is growing. So the first time the hospitalist word was, came into the scene was in mid 1990s, and since then, it started in US. It flourished very quickly. It's the largest and most rapidly growing specialty. In Canada, it's a little bit lagging behind, but it started in early 2000, and the concept is growing rapidly.
Sorry to interrupt, but wasn't this job being done before this was being done by internal medicine?
Internal medicine, to an extent, you can say, but the internal medicine would have their own unit, and they will
Right.
admit patients in that unit.
Right.
However, for example, in in a neurology unit, or say in an oncology unit, the patient will be managed by the neurologist, and they will have to consult the medicine if they need it.
Right.
The newer concept is that people within the each even specialty unit, they need hospitalists to manage their patients as a whole. So as an example, now in many hospitals, division of neurology or oncology or surgery, they are having hospitalists to manage their inpatients, because they can oversee their all various aspects like diabetes, high blood pressure, or if they develop a pneumonia or UTA, they can manage that. While the specialty, the unit, for example, if it's oncology, they will manage their oncological aspects or surgical aspects. So to answer your question, it is growing in different hospitals, and each hospital might have a different setup of hospitalists. In community hospitals, if you go outside the bigger centers, the model is anybody who's admitted from emergency goes under hospitalist care. They could be a mixture of medicine, surgery, orthopedic patient, but they go under a hospitalist, and the other specialties will consult with them depending on where the need is. And in the subacute care level, where people are going for rehab or
Like
complex
Providence
cardiac
Care.
care, it will be overseen by the hospitalist entirely. And in a tertiary care hospital, as I said, the different specialties now are more and more relying on the hospitalist to manage the inpatients. So they don't have to consult, like, for example, medicine or other specialties, for simple things.
So you manage their care in the hospital. And what about once they're discharged? Isn't there a chance of their care falling through the cracks, whether it's their medical care or mental health care?
It's a very good question, and I think this speaks to the issue we are dealing here in Canada and Ontario about having lack of access to primary care. Uh, there are thousands of people, as you know, who are not attached with family doctor. So this is a challenge. When we are discharging patient, we try our best to see what kind of follow up care can be provided. And if there is no family physician attached, we try to, if they need to have a link with a particular specialty, we'll arrange that follow up. There is a growing concept of nurse practitioner as well in primary care. and I think that also is helping to bridge that gap. But 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 really, I mean, that challenge, it is a problem which there's no solution yet. And i and i know that there has been a lot of talk about the lack of primary care, but there are no clear practical solutions yet.
The need for hospital beds is everywhere.
Yes.
And again, I'm thinking in terms of discharging an individual without primary care support, could there be some kind of a step down approach, perhaps? But again, I think that those are probably for the policymakers to decide. Let me ask you this. So, what can outpatient clinics, for example, like Summit Neurocare, do to help support patients who are admitted under your care, your division's care, have also other psychiatric conditions that need ongoing follow-up?
I think that's a great question, and I think it's well known that access to psychiatrists in community is very difficult. And I think I appreciate that Summit Neurocare started this initiative in Kingston, where they are have developed this community program and access to the patients. And I think definitely the system needs more of that. So if, for example, if we have a patient, who is admitted and they are diagnosed or maybe develop a new mental health condition like depression or anxiety, or they have existing which got worsened during the stay, and if we can have an easier access to a psychiatrist in community, it will definitely have a huge impact in their health journey. Rehab doesn't stop when the patient goes out of the hospital. It's a continuous journey,
Right.
and there is no health without mental health. So we need to have that component going on in order for them to continue their rehab journey and stay in the community and don't end up back in the hospital.
Right.
So definitely more and rapid and easy access to community psychiatry programs is a huge benefit.
So we're coming to the end. If you could change one thing about mental health in hospital as a hospitalist, what would that be?
I would just say that I hope that every hospital has an access to psychotherapy, as well as an access and ability to consult psychiatry for challenging patients.
Okay. And lastly, one practical tip for clinicians to better support patients with mental health issues on the ward.
I think they should have a low threshold to consider mental health as a factor in their rehab journey. They should be vigilant to identify early signs of depression and anxiety, because that can change the trajectory of rehab immensely.
I think an important thing is also the carers of people with the mental health difficulties, whether they are on a psychiatry ward or your wards. And it's also the importance of showing empathy and support to carers who have somebody, a loved one in hospital with mental health challenges as well. Thank you very much. Really appreciate your time. It's been an absolute pleasure to get your expert opinion on this topic, not well known, and wishing you the best in your future endeavors. Thank you very much, Dr.
Thank you
Rashid.
so much. It's always a pleasure to meet you, and thanks for inviting.